group 6, and we're going to be talking about gender identity. Introduction. Michelle is a 39 years old Caucasian trans man who also identifies as a gender fluid. He explains that he has always felt that something was wrong with him. He has felt that his body was a prison for most of his life. He identified as a lesbian for most of his adolescence and was kicked out of her house at the age of 15. You might wonder, what does Michael life has to do with this presentation? Well, in this group project presentation, my team and I were going to inform you about what exactly is gender identity, the dimensions of the gender, the spectrum, and we'll provide some details about what the case study is in reference to Michael. So we're gonna go over deeper into exactly what is the life of Michelle, who is 39 years old. And we're also gonna talk about the treatment as well as the bias and ethical concerns. So moving forward, we have here Taylor. Taylor there?
Hi everyone, I'm going to go over the DSM definition. The gender identity disorders are defined as disorders in which an individual exhibits marked and persistent identification with the opposite sex and persistent discomfort, dysphoria with his or her own sex, or sense of inappropriateness in the gender role of that sex. The proposed criteria are for the updated DSM, which are a marked incongruence between one's experience, expressed gender, and assigned gender of at least 6 months duration, as manifested by 2 or more of the following indicators. 1, a marked incongruence between one experienced expressed gender and primary and or secondary sex characteristics, or in young adolescents that anticipated secondary sex characteristics. 2, a strong desire to be rid of one's primary and or secondary sex characteristics because of a marked incongruence with one's experienced or expressed gender. 3, a strong desire for the primary and or secondary sex characteristics of the other gender. 4, a strong desire to be of this other gender or some alternative gender different than one's assigned gender. 5, a strong desire to be treated as the other gender. 6, a strong conviction that one has the typical feelings and reactions of the other gender. The 2 major changes of the criteria are 1, framing of the disorder in terms of the incongruence between experienced gender and assigned gender instead of a cross-gender identification. And 2, the removal of distress or impairment as a requirement for diagnosis. These changes refine the criteria to be more reflective of the current clinical presentation of people who are going or experiencing GID.
So I will explain the gender unicorn. This is typically a infographic that is used to help explain to individuals what exactly gender identity and expression are. It differentiates between sex assigned at birth, your gender expression, and how you which gender you identify with. It also goes into explain sexual attractiveness and emotional attraction. Next slide.
Gender identities. Gender identity is a person's inherent sense of being male, female, or an alternative gender. The gender identities include cisgender, which is a person whose gender identity and expression align with their sex assigned at birth. Transgender is an umbrella term used to describe people whose gender identity or expression do not conform to what is associated with their sex at birth. Genderqueer is a person whose gender identity does not align with binary understanding of gender. Gender nonconforming exhibits behavioral, cultural, or psychological traits that do not correspond with the traits typically associated with one's sex at birth. and gender neutral, does not conform to either sex, but just as a person in general. And then next is sexual orientation, which refers to the sex of those to whom one is sexually and romantically attracted. Heterosexual is one who's attracted to members of the opposite sex. Lesbian or gay are attracted to the same sex. Bisexual is one who's attracted to members of both sex or all sexes. Pansexual is one whose attraction is not limited to a particular gender identity or sexual orientation. Asexual does not feel sexual attraction at all. And intersex is the condition of having either both male and female organs, or of having the gonads of one sex and external genitalia that is of the other sex or ambiguous. And then the other two that I've heard too are omnisexual, which is similar to pansexual, and then demisexual, which is one who feels sexual attraction towards a person with whom they have an already established connection. So the next one is gender and sexual orientation. This is for adolescents. In adolescence, gender and sexual orientation, diverse students report an increased school connectedness and school safety when the school personnel intervene in the following ways. They address and stop bullying and harassment, develop administrative policies that prohibit discrimination based on sexual orientation, gender identity, and gender expression, supporting the use of affirming classroom activities and the establishment of gender and sexual orientation, diverse affirming student groups, and valuing education and training for students and staff on the needs of gender and sexual orientation diverse students. Gender and sexual orientation diverse children and adolescents who are victimized in school are at increased risk for mental health problems, suicidal ideation and attempts, substance use, high risk sexual activity, and poor academic outcomes, such as high level of absenteeism, low GPAs, and low interest in pursuing post-secondary education. And then for adults, research has documented the extensive experiences of stigma and discrimination reported by transgender and gender non-conforming people, and the mental health consequences of these experiences across the lifespan, including increased rates of depression and suicidality. Transgender and gender non-conforming people's lack of access to trans-affirmative mental and physical health care is also a common barrier, with these people sometimes being denied care because of their gender identity.
Okay, so our scenario, our case study that we're going to be doing our treatment plan on is for our client named Michael, who is a 39-year-old Caucasian individual who is gender non-conforming and gender fluid. He prefers to use male pronouns. He has recently moved to a conservative rural town in Northern California with his twins, who are 4 years old. He currently does not work and lives on his Social Security disability. He is not currently prescribed medications, but uses THC for self-medicating. He explains that he has always felt off and that something was wrong with him. He has felt that his body was a prison for most of his life. He was raised in a heavily religious household in the South. He identified as a lesbian for most of his adolescence and was kicked out of his home at age 15. Michael spent his adolescence and young adulthood as homeless on the streets of San Francisco. During this time, he reports that he was often assaulted physically and sexually due to his identifying as a lesbian. It was also during this time that he started to recognize that he was born in the wrong gender body and that he was truly a man stuck in a woman's body. Due to his constant feelings of hopelessness, worthlessness, and not feeling right in his skin, Michael was often suicidal and spent the better part of his adulthood in and out of psychiatric hospitals. His last hospitalization was 4 years ago when his youngest children were born. From the ages of 21 to 35, Michael gave birth to 6 children, including 2 sets of twins. All were taken into Child Protective Services with exception of the twins that he currently cares for. He believes that this is due to his gender identity and being the victim of prejudice. Michael is not in contact with his children's biological father and prefers to have his children call him either mom or dad, depending on how he is expressing his gender that day. So the presenting challenges, upon initial assessment, Michael presents as a middle-aged white woman dressing in a dress, short heels, dangling earrings, necklaces, bracelets, and wearing makeup. He reports that he chooses to dress in traditional women's clothing because it is the most comfortable clothing to wear and feels that they are pretty. He states that his symptoms are feeling overwhelmed and anxious, feeling as though he can't breathe, shaking, unable to concentrate or control his worry. He reports that he has difficulty sleeping due to worries about his twins and if they will be taken away like his other children. He feels that he is failing as a parent and can't do enough for his children as they are together the entire day with no breaks. He has no other childcare and has been doing it alone since their birth. He worries that those in his new local community will attack him for identifying as gender fluid. He feels that he is unable to be honest with his new neighbors about who he is, which is causing him to isolate from his community. He would like to be able to make friends and create a community for himself and his children, but is scared to leave his home at times. He has no natural supports as he has no contact with his family and does not want to keep in contact with his friends from San Francisco.
Okay, so some of the basic information a clinician needs to know would include information from their biopsychosocial assessment or intake assessment. And that could be what brings them to therapy. Is it self-referred, court mandated? History of presenting problem, how long the current problem or problems have been bothering them, goals that they would like to accomplish, more about family system and dynamics. Who do they currently live with? Who do they primarily rely on for support? How was it like growing up for them? More about parenting styles and discipline styles. Environment, so at home, work, school, community, social settings. Any history of trauma or psychiatric history. Developmental history, their socioeconomic status, cultural, ethnic background, spiritual, religious factors, any health conditions or medications that they're taking. Have they ever or do they now use any substances? More about any suicidal ideation, history of any treatment, and if so, what was done previously? And then knowing more about some of their strengths, needs, abilities, and preferences. And then specific information we need to know. So according to leading experts in LGBT health, the following questions are recommended based on testing with rural and urban health centers and other studies of sexual orientation and gender identity data collection, such as research conducted by the Center of Excellence for Transgender Health at UCSF. So for sexual orientation, do you think of yourself as straight or heterosexual, lesbian or gay, bisexual, queer, pansexual, and or questioning, or don't know, or still exploring? Gender identity, do you think of yourself as male, female, transgender man, transgender woman, genderqueer, gender nonconforming, neither exclusively male nor female or other? And for Michael, he does identify as being gender fluid. We also want to know more about gender affirmation, preferred name, preferred pronouns. And with Michael, it was he, him. And it was also mentioned that he prefers to have his children call him either mom or dad. We want to know more about administrative sex. So that could be used for administrative purposes such as insurance billing and also birth sex. We also want to consider impact of social media, peer influences, and support when navigating and exploring self-identity. And with this, it was mentioned that Michael did not have any natural supports. And not a lot of communication with the biological fathers of his children or even family, and didn't even want to be in contact with any of his friends in San Francisco. Then there's safety concerns and boundaries, and also resources and psychoeducation. And this could be for the LGBT community and also like parenting resources.
Now I'm going to talk about the treatment plan. The diagnosis that I have for Michael, and I apologize for the beginning, I call him Michelle, but it is Michael. So the diagnosis, I have him as a persistent depressive disorder or dysthymia, anxiety disorder, and post-traumatic stress disorder. Current medication, Kelly, I'm not sure, is Michael taking medication? He's not on medication currently, nor he used drugs. The presenting problem is anxiety, dysthymia, and post-traumatic stress disorder. So the first one that I'm gonna explain here in regards to the treatment for anxiety. Michael's anxiety has been identified as an active problem that requires treatment. It is primary evidence, but according to the DNIC, he worries that those in his community will attack him for identifying as trans, feelings overwhelmed, anxious, feeling as if he can breathe, shaking, unable to concentrate or control his worry. As a long term, Michael will reduce overall level, frequency, and intensity of anxiety, so daily functioning is not impaired, and the target there will be 3 months. The short-term goal is Michael will work with therapists to identify conflicts from the past and the present that form the basis for the present anxiety. The sessions would be once a week, 45 minutes, and it's gonna be assessed ongoing. And the next session with Michael will be August 6th. The intervention would be, we're gonna be using CBT, I mean to write here CBT, and DBT. Therapists will assist Michael in developing reality-based positive cognitive management messages that will increase self-confidence and therapy and thereby decrease anxiety. He will progress, the progress will be monitored accordingly to the sessions every time that he comes to session. Again, so it will be once a week during the 45 minutes. That is in regards to anxiety. Moving forward, with persistent depressive disorder, dysthymia, many times it is also called as depression. Michael depressed mood has been identified as an active problem requiring treatment, as evidenced by depressed mood is present all the time. He complains about feeling hopeless, worthless, and not feeling right on his skin. He is often suicidal and spends part of his adult in and out of a psychiatric hospital. The long-term goal would be Michael will report depressed mood less than once a week. And this will be targeted by 3 months. The short-term goal will be Michael will keep a journal to express thoughts and feelings related to the loss. This will help Michael learn about the relationship between feelings and mood, and identify and explore mood as they are experienced. Michael will share journals with therapists weekly with the goal of depressed mood occurring less than 3 times per week. That's also going to be assessed on a weekly basis. The interventions again is going to be CBT and DBT. Psychotherapists, the recommendation is for Michael to participate in psychotherapy, but also medication or antidepressants. Therapists will assist Michael pinpoint negative thoughts, patterns that result in persistent sadness and despair to decrease symptoms of depression. And progress will be monitored on a weekly basis during this session. Again, I come up with 2 or 3 short-term goals as long as interventions. However, due to space, I only select one that I thought it was the most important to have it posted here on the PowerPoint. Moving forward, we have post-traumatic stress disorder. Michael's mood has been identified as an active problem requiring treatment, and it is evidenced by the trauma experienced when he was kicked out of his coma at the age of 50. Homeless on the streets of San Francisco, he was assaulted physically and sexually. He's victim of prejudice, and he lost custody of his children. So we can identify that all these factors or situations that he experienced in life are sources of trauma. Definition criteria, this is something that I did not saw on the vignette, whether he was presenting any nightmares, whether he was hypervigilance, exaggerated. So he did not meet criteria according to the vignette. However, due to the trauma that he experienced during his adolescence and when he was living homeless in San Francisco, I assumed that he had post-traumatic stress disorder. Long-term goals, Michael will ease the PTSD symptoms, making them less frequent and less intrusive or impactful on his life. He will restore a positive sense of self and self-esteem. The target will be 3 months. Short-term goal, Michael will correct irrational thinking, which leads to PTSD and interpersonal problems. Frequency one time a week, and again 45 minutes. The interventions, CBT and DBT, therapists will assist Michael in identifying and addressing specific areas of cognitive distortion, such as thinking, anxiety, guilt, survivor guilt, blaming self for being a victim, such as rape, and catastrophizing. As I mentioned before, even though in the vignette is not stated about him presenting any symptoms about PTSD, he doesn't meet criteria. However, I just add that as an addition. Moving forward, we have Naomi.
So I'll be covering some of the personal bias that we as therapists can see within treating individuals who have are questioning their gender identity. And so something that makes us unique as clinicians is our background, our experience, our cultures, our social groups, and our own trauma. We bring so much with us to therapy that can be so positive. However, on the flip side, we can also bring the biases of these experiences with us. Something that we have to keep in mind is refraining from having that bias affect treatment. And so whether it's our cultures or our religions or the morals that we've grown up with, we have to remember as clinicians to keep those separate from our practice. When we are starting to feel those feelings of dread or not wanting to engage with individuals due to things that are going on in their life, we need to be able to seek support of supervision to make sure that that is staying out of our practice. And then going over some of the ethical concerns. So from the Code of Ethics, as clinicians, we have the responsibility to patients, which is 1.1. Marriage and family therapists do not condone or engage in discrimination or refuse professional services to anyone based on anything, whether it's gender, race, identity, gender expression, all of these things we have to be able to serve our clients. 1.1.1 is the historical and social prejudices. So we are not going to be engaging in social prejudices when diagnosing and training patients because of that can lead to misdiagnosis and pathologizing patients. 1.4.1 is we have to respect our clients' choices. So being able to work with them on their goals and leaving our own feelings out of therapy and treatment. We also, in 1.5, we share what we are able to inform our clients, but also respecting our clients to, if they know about our backgrounds, we have to be able to remain neutral in those therapeutic relationships and being honest with our clients. And in 1.5.6, the therapist background, we are informing our clients of the treatment, of the training and the education that we have, whether it's specializing in working with individuals who are questioning their gender identity or sexual expression, any of those things. We have to be able to do that when it is appropriate. It's not usually the first thing that we say first session, but as it gradually comes up, we can share those things with our clients. And so part of that is we want to avoid the assumption that every transgender or every gender conforming patient who is seeking treatment is struggling with gender dysphoria or seeking a referral letter for gender affirming surgeries. We can't assume that as a therapist that is the end goal. We have to be able to work with our clients in seeing what they need help with for clinical issues such as anxiety, depression, grief, stress, and other related topics that come up. And so WPATH, which is the World Professional Association for Transgender Health, this is a nonprofit who works with clinicians who are looking for more information and support when working with transgender or gender non-conforming individuals, and making sure that we're following the right steps and having the education that we need to be working with individuals, especially if there is a request to have that letter supporting them getting gender confirming surgeries. And so that isn't for everybody. As a marriage and family trainee, we can't do that, and it's not recommended for pre-licensed marriage and family therapists to be giving these letters, because we usually don't have all the training that we need, and we want to be able to make sure that that is something that we have the education on in order to support our clients. Something else, so for clinicians, we also have to make sure that we know that we don't have to have these gender affirming surgeries to be able to call our clients by their preferred pronouns. When that is something that is brought up, our clients, we can always go ahead and use their preferred pronouns. And so these are some of the things that are pretty important for working with gender non-conforming patients and transgender individuals.
And for our conclusion, we're going to go over why we think gender identity was an important topic. For me, it's just because it's the core of who we are, and you can learn a lot about a person by getting to know their gender identity and getting to know them. Next.
I believe that knowing exactly what gender identity is, it is important, because it is the best way that we can be with the client in the journey, trying to identify where he's at and where he wants to be. Because if we don't know where he's at, more likely we're gonna get him or her even more lost.
I think this is an important topic because we need to be sensitive to biases and lifestyles. The more we're educated, the better we can be at, our profession as a therapist.
I believe that this is one of the most important topics because gender questioning and transgender individuals are one of the most vulnerable populations in our society, especially with the rates of suicidal actions are higher than most other groups. I believe that the more we talk about gender and the spectrum that it is, the less taboo it would be. We would be better capable of helping all of our clients.
And for me, this topic was unfamiliar, and I kind of just knew the basics. But I think it's important because it brings awareness, like a better understanding and advocacy for gender identity.
For me, I think it is extremely important. I work with a lot of teens who are going through this process, whether it's already in the transition or looking to define their identity and who they are as a person. And so being able to support them is important to me as a future therapist and helping them find their path. And so we'll move on to our references and we are done.
And with this, we conclude the presentation for group 6. Thank you.